Have you ever signed a contract and immediately wondered if you left money on the table? Well, that feeling doesn't go away. It sits there for 13 weeks, reminding you that you took the first decent number you saw because you were tired of looking. Tallywise lets you upload that offer and watch other employers try to beat it. Tallywise, get a better offer, guaranteed.
You're listening to Nurse Converse, presented by Nurse.org, a collaborative podcast amplifying diverse nurse voices. Get ready for a dose of inspiration, a sprinkle of education, and a whole lot of community.
Hey guys, it's Nurse Jana, and welcome back to an episode of Nurse Converse with Nurse.org. I am incredibly excited today to have Claire Barnett on. I met Claire at a BCEN conference. It's a Board of Certification for Emergency Nurses in Destin, Florida. And weirdly, we had been outside petting some puppies that they brought in for all the conference goers and kind of met Claire. And the next thing I know, Claire's up on the stage speaking, and does she have an amazing story to tell? So Claire Barnett is a quadruple board certified emergency nurse in emergency nursing, trauma nursing, pediatric emergency nursing, and flight nursing. And she comes with a wealth of knowledge and experience, but a story that you guys are never, ever going to forget. So, Claire, let's get into it. Why don't you tell us a little bit about yourself, where you live, what kind of nursing you're doing right now, and how you got here. And then we're going to go into this awesome, amazing story that you have to tell.
Thanks, Jana. You make me sound way better than I am, first of all. I'm just a regular plain old nurse. So I currently work for a long distance international flight medevac company. I'm the chief flight nurse. We do transports within the US, and also we go outside, mostly up and down the Western Hemisphere, Japan, New Zealand, Hawaii, repatriating people back into the country after they get hurt or sick on vacation. So that's my current job. How did I get here? I grew up in England and moved here when I was 17. Met a cool guy, got a cool job. I was a concrete dispatcher. And my number one driver, this is a long story, I'm going to make it short. My number one driver, he was about a year away from retirement. He got really sick. He got a rare disease that they gave him 6 months to live. And this gentleman had worked his whole life as this concrete driver. And it devastated me as a dispatcher that he wasn't going to enjoy his retirement. And so I was very, very naive. This is like 20 years ago. I got on the phone with a bunch of hospitals. Somehow I got hold of somebody at Sloan Kettering, which I didn't even know what that was at the time. And they told me about some experimental trials they were doing for this particular disease, but they weren't doing them on the West Coast yet. So I got really angry about it and was like, that's not right. They ended up opening up an experimental trial up in Seattle that I was able to get him into. And he went through stem cell transplant, got really sick, but ended up coming through it and lived for another 10 years. Long story short. I got to thinking that if I could do that with no experience, think of what I could do with actual training. And so that started my journey to nursing. And that's how I ended up being a nurse. Spent 7 years in a critical access hospital, 7 years in a level 2 trauma center, always wanted to fly. From the time that I took my first trauma patient that got flown out of the critical access hospital, and the flight nurse came in and put his hand on my shoulder and said, good job, we got it from here. I was hero worship. That is what I want to do. I want to be that person that goes into the room, makes everything better. Everybody loves it. Everybody loves me. I can do whatever. So basically flew part-time for the company that I now work for, spent 2.5 years working on a helicopter, and then I end up going back to the company that I worked for before as chief flight nurse full-time. So that's how I got here.
I'm laughing because you're like, I'm just a plain old nurse, but the story that you tell before you even became a nurse is incredible. The fact that you weren't even a nurse and you went out and you helped somebody like that, that's just, you really are an inspiration. So, which makes this story that you're about to tell just mean even so much more, because I didn't know that part from the conference, and now I have so much more, even more respect for you now. So, Guys, at the conference, it was, if you've never been to a BCEN conference, you do not have to be certified to go. It was fantastic. But some of the stories that came out of there were just, I walked away feeling so proud to be a nurse with these stories, and just honored that these are people that call themselves nurses, and I get to call myself a nurse as well. And when Claire got up to tell her story, you couldn't hear a pin drop. It was incredible. And there were, with a lot that's going on, Claire, with flight nursing, it's really important that we talk about this, because there are dangers in nursing, period. We all know what's going on in nursing right now, violence and short staffing. There's just, nursing is, for lack of a better word, it's become a very dangerous profession to save lives. Very, very dangerous. And the things that we do to save lives have now put our lives in danger. And you found yourself in that same spot. So take us to the story. Tell us how it started out, when it was, and let's go from there.
All right. So about a year and a half ago, I was flying out of one of the Southwest states, out of a very remote area. I'd been on the helicopter for about a year, so I still felt new, but I was proficient enough to be able to train another person. So the size helicopters that we flew down there, you could only fit 2 clinicians in the back. So usually when you start flying, you put 3 clinicians together, 2 experienced and 1 inexperienced. So you have a good solid crew with somebody to learn. But in the helicopter, it's a little bit different. You can only fit 2 people in there. So I had a trainee who was very proficient in flight clinician care. She had flown on a fixed wing, but not on a helicopter. So it was just herself and I. It was her second hitch. So new to the job, new to the helicopter, but proficient in medical care. So wonderful partner. We had done a perfectly uneventful flight, taken some pictures. Everything was great. We flew back to base. It was February, so middle of the winter, but in the Southwest, clear blue skies, everything looked great. So got back to the base, grabbed something to eat. We get dispatched for a flight. As a flight clinician, when you get dispatched for a flight, you're not told anything about the patient. You have to accept or deny the flight based on unbiased information. So, if you find out you're transporting a 3-month-old baby that will die if you don't, of course you're going to take risks. So they don't tell you that information. They only tell you where you're going, and that's it. Where you have to pick up the patient and where you have to drop them off. So you talk to your pilot, talk to your partner together, come up with a decision on whether this is a safe flight to take. We looked at the weather, and there was a storm system coming in. And according to the weather reports, we looked at all of them. We had about 2 to 4 hours before it hit us. And according to the flight that we taken, it would take about 30 minutes to go pick up the patient, an hour to take them to where they were going, an hour to get back to base. So the chances were we wouldn't make it back to base, but we could still take the patient where they needed to go. We agreed that this was an acceptable thing to do. When a storm comes in, we fly patients off of a very remote area. They have no resources there. When storms come in, that's when people die, because they have limited resources. Their hospitals, clinics get overwhelmed. And so we did feel a little bit of pressure. We should go get this patient because a storm is coming in, and that's when things get rough. We don't need to get back to base. We can hotel wherever we're going. We just need to get this patient to a higher level of care. So we agree to take this flight. We also have some contingency plans. If we get up in the air and things look bad, we come back home and we land and we call it. So we did have backup plans. So we felt that all the decisions we were making were the right ones. So then we find out about the patient. This is a young man in his mid-30s. He has possible hantavirus. If you don't know what hantavirus is, it's quite prolific out where we were flying. It is a disease that progresses very quickly. You get it from mouse droppings. It's respiratory. You get pulmonary edema, real difficult to ventilate. I've flown a couple of hantavirus patients before, and they're some of the sickest patients you'll get. You just can't ventilate them. Sometimes you have to take them off of the ventilator and bag them, just be able to ventilate them. Wow. So we know this guy was sick. So we pack all our equipment, calculate our oxygen. So this gentleman's on high flow. we don't have high flow capability at that time in the helicopter. So we looked at our options. We could put him on BiPAP, but that's not always the safest, because BiPAP in flight, if you have any kind of a leak coming out of the mask, it can run through your oxygen and then you'll run out of oxygen in the air, which is the worst thing you ever want to have happen. We could intubate him. We did talk about that. That was a possibility. We could intubate him for the flight. I'll talk a bit more about that when we get to the facility. Or we could just put them on a non-rebreather. And a lot of times people do really well that are on high flow on a non-rebreather for short periods of time. So we felt that we could go to the bedside and figure this out. So we lift off and we head to the facility. As we're landing at the facility, we can actually see the leading edge of the storm. It doesn't look like it's moving very fast, but we were able to see it. So as we landed, we talked to our pilot and agreed that our pilot would wait outside with the helicopter. And if it started getting too close, then we would either stay there or we would head out. Fortunately, the storm is coming in from an opposite direction from what we had to go. So it could get quite close and we could still safely take off in the direction that we were going. So felt pretty comfortable with the plan, thought that was good. So got to the bedside. The patient is very, very tachypneic, breathing between 40 and 50 times a minute. He's severely hypoxic. When we switched him over to our equipment, he actually desatted into the 70s pretty quickly. So yeah, we decided, and he was alert and oriented, so I couldn't justify intubating him. We put him on a non-rebreather and he tolerated that well. So we decided that that was the right route to go. We have enough oxygen for, I think we calculated 2 to 2.5 hours on that non-rebreather. Plenty of time for the 1 hour flight. Good to go. We're all happy. Load the patient up, take him out to the helicopter. And when we got out to the helicopter, that storm's pretty close. Like I was like, ooh, that's pretty close. So talked to the pilot and I was like, hey, bro, we good? And he's like, yes. He said, we're going in the opposite direction. If we can package him up, like get him inside the helicopter pretty quickly, we're good to go. This pilot has been a pilot in that area for 5 years. And I actually, to this day, I do still implicitly trust him with his decision making. And so talked to my partner a little bit. Of course, my poor partner, who's, it's her second hitch, she's like, oh yeah, I'm good. Yeah, that's great. Load the patient up and off we go. Bless her heart. I still fly with her. I don't fly with her. I flew with her for a year after that until I left. She became my permanent partner. One of the best partners I ever had. Anyway, side note, we go ahead and we take off. And in order to get out of this area that we were in to the area that we were going, we had to actually go up over kind of a mesa. It's like a mesa is a big mountain with a plateau on top of it. And it lasts, it kind of goes lengthways a ways. And so we've been in flight for about 10 to 15 minutes. And we get up to this mesa and the ceiling has come down to where we couldn't get up over on the route that we wanted to go. So we, pilot tells us, and his communication was phenomenal. He turned around and he said, hey, I can't get up over. We're going to fly to the left a little bit and I'll try to find a way through. And this is not abnormal for this area. We've done this multiple times. You just have to see a clear path through. We're not going into the clouds. We're not doing anything illegal. So this was a common practice and nothing that had me concerned. So we head off to the left and I'm still kind of doing patient care. So every now and then I glance up and I can tell he's trying to find a way up over this mesa. About 5 minutes later, he turns and he said, hey, I can't get through. I'm going to turn around and we're going to go back to the facility. So I'm like, okay, yeah, not a problem. That was the plan that we had. And that's just what we have to do. So we turn around, we turn the helicopter around, and literally right in front of us now, facing the other way, is the storm. It is right there, and it has closed in behind us. So we're surrounded by a storm that we can't get through. One thing I forgot to say earlier is helicopters don't fly in the clouds. There's something called spatial awareness that you lose when you get into the clouds. You don't know what's up, down, sideways. And this is actually what kills so many helicopter pilots and passengers, is they inadvertently get into this cloud condition and you don't know what's up or down. So very, very dangerous. So pilot brilliantly says, I'm going to set down. It's the safest thing to do. I'm just going to get down on the ground, which we were like, yep, good idea. He said, I'm going to land. So go ahead.
You're in
Yep,
the
middle
middle
of
of
nowhere.
nowhere.
Yep, middle of nowhere. No, we couldn't see any roads, no nothing. I know.
No.
Um,
I heard this story once, but I'm telling you right now, I wish you could see my hands. They're sweating. I'm
um, so we're kind of flying over a canyon, and he's like, I'm going to land in the canyon because then we'll be out of the weather. And something about this, I was just like, no, don't land in the canyon. Let's try to find a road somewhere. And so he's like, okay, I'll briefly try to find one, but then we have to get on the ground. So we actually did see, after 10 seconds of flying, just this like looked like a little ATV trail, kind of I'd say it was a dirt road, but it's covered in snow because at this point it's February, everything's covered in snow up there. We're probably at about 7,500, 8,000 feet at that point of elevation. And so no roads, anything like that. So we see this little trail, and I'm like, okay, it's set down there. And this is something I didn't really think about it. But when we started to set down, we're setting down on the snow. I got a little bit concerned because you don't know what's underneath the snow. Are we setting down on a fence? Are we setting down on some farm equipment? Like, what is under the snow? You don't know, right? So that was really I got a little nervous setting down, but we sat down, and then within, I'd say 2 minutes of setting down, we were in a complete whiteout. The blizzard hit, and we couldn't see anything. We're totally in the middle of nowhere with this super sick patient. And so a feeling of relief initially, because you're on the ground, so you're safe. But then you start thinking about, now what? What do we do now? We have this patient, and we have this oxygen that he needs that we're going to run out of. So we talk briefly about, let's keep the helicopter running until we have to shut it down for fuel purposes. We'll leave enough fuel on board to be able to get out of here if the storm clears, but we want to keep warm, right? This is a legit blizzard. So we agreed we'd keep the helicopter running. We plugged all of our equipment in, made sure our batteries were all charged. We had no cell service, but we were able to reach dispatch on the sat phone to let them know, give them coordinates. So this all sort of happened at the same time. Our pilot called dispatch and gave them the coordinates of where we're at, told them we had a sick patient and they needed to get somebody out here. So dispatch says, sure, we'll call you back. At that point, I was talking to my partner, and we need to actually get this guy on some different form of oxygen, because right now we're going to run out of oxygen in 2 hours if we're on this normal breather. And I'm not sure how long it's going to take people to get up here, because we are legitimately in the middle of nowhere. So
in a storm, in a blizzard,
in a blizzard, correct, right? And so we had a lot of discussion about the best oxygen delivery for him to preserve our oxygen. And all I kept thinking about was, if we could just find a way to where he only got oxygen when he breathed. So oxygen on demand. Because I know that there's, older people out there that have oxygen concentrators that actually go off when they take a breath, right? So in my mind, that was similar to what a BiPAP would do, but I didn't want to put him on BiPAP because I didn't want to run through our oxygen. We did talk about intubating him, because intubation is the safest form of oxygen control that you can have. But we discussed, if we were to intubate him, we'd have to use oxygen to pre-oxygenate him in order to intubate him, which would, run our oxygen down a little bit. And then the other part was, I'd only been flying for a year. I actually had never intubated a patient yet. And that scared the heck out of me. I mean, I've done tons of mannequin intubations, and I'm not going to be like, oh yeah, I can do this. It was terrifying, because I do believe that when you make the choice to intubate a patient, you're sort of signing a contract for their life at that point, right? I'm taking the one tool away from you that you need to live, and I'm going to do that myself. And so I had better know what I'm doing. And that was the worst scenario for an intubation that I could think of. Running out of oxygen, middle of a blizzard, tiny little helicopter, and it's dark.
It's Nurses Month, and we're celebrating big at Nurse.org. We're not just doing one giveaway, we're giving away hundreds of prizes all month long. That's right, you can win instantly and enter every single day. We're talking Amazon, Visa, Walmart, Starbucks gift cards, plus shoes, scrubs, and so much more from brands nurses actually love. Don't miss out. Head to nurse.org/win to enter now through May 31st. And make sure you're following at nurse.org on Instagram for even more chances to win all month long.
You just have to take those factors into consideration. So we have something on board called a RAM cannula, and that is basically a big nasal cannula that they use for children for basically putting them on BiPAP without having a mask, because kids don't tolerate it. So it's a nasal cannula that's large that interfaces with a ventilator, and you can put like a little bit of goop around their nose to create a seal. And if you can keep their mouth closed, it's essentially BiPAP. So we carry these for kids, and we decided to put this on our patient and put the ventilator on a BiPAP setting. So whenever the patient took a breath, it would give him oxygen. It would trigger the ventilator to give him a little bit of oxygen. All the oxygen would go into his lungs, rather than, as opposed to a nasal cannula where they're just getting the free flow of oxygen, and you lose it, you don't need it, because we're thinking oxygen conservation. And so we actually set him up with this RAM cannula on the ventilator, gooped his nose up, kept his mouth shut. But then we have the problem that he's tachypneic, right? So he's breathing 40 to 50 times a minute. What do you do? So totally out of protocol. And this is what's crazy, because these are things that nurses might lose their license over, as far as you're doing something that, gosh, you're doing something you probably shouldn't be doing. But I didn't feel like I had any choice at this point. So I gave this patient Ativan. I gave him a lot of Ativan. I slowed his breathing down. And I did not know if I was taking away his compensation. I actually didn't know, but it was the only thing I could think of to slow his breathing down so that he wasn't burning through our oxygen. Because once he burned through that oxygen, I had no doubt in my mind that he was going to die. Like, no doubt, to the point where we even discussed, once we switched him over, what we were going to do with him when he died, because we didn't know when we were going to be able to be rescued. In the midst of all this, we'd gotten a phone call from dispatch that said that they got a hold of search and rescue. Search and rescue told us that they actually had a call in that same area earlier that day that they were not able to get to for whatever reason. It was just a very remote area with a lot of difficulties. So they had told us at that time that they actually didn't know if anybody was going to be able to come up and get us. So we really started thinking about what we were going to do with this patient when he passed away. Of course, we didn't discuss that until we had enough Ativan on board that he couldn't hear us, but that was a very genuine discussion. Yeah. So switched him over, gave him Ativan, did get his breathing down to about 12 times a minute. I had learned years and years ago from a very wise doctor that you can't actually kill anybody with Ativan. We had a patient that came into the ER that had an Ativan overdose, and he was like, I'm not worried about this. You can't die from Ativan. So that always stuck with me randomly. And I thought, and so that's why I chose Ativan. It's like, I'm not going to kill this patient, not intentionally, but I'm sure going to slow his breathing down.
What you had to do in that moment? You were,
yeah.
What do you do? You were thinking,
yeah,
critically thinking, as we are trained to do as nurses, to try to do your best to save this patient's life. While let's just go ahead and mention, you guys' lives were also in danger. You're in the middle of a storm in a helicopter, not knowing if anybody's going to come get you, and you don't know what the weather conditions are going to be like. Your life is in danger. That patient's life is in danger. You did the best with what you've got. So, yeah. So you've got him. You've got his Ativan on board. You're breathing, and now you guys are having some serious conversations.
Yep. So at this point, and it's funny because you talk about, our lives were in risk, but I promise you that thought never entered my mind until later on. So at that point, we're still sort of focused on the patient. So now we're having the conversations of, it's been an hour and a half. We have to shut the helicopter off because we need to leave enough fuel on board to be able to fly out if we need to, which we probably wouldn't be able to do anyway, because everything's iced up. Once you shut it down, things ice up and you can't fly it. So we have what we call a helicopter confessional. We tell each other things. We talk to each other. We really keep the mood light. And that is what they tell you in survival training, is your mindset is the only way that you will survive something. So we have these conversations about, our lives, our families, everything. I mean, we tell each other everything. It made the time go by quite fast, but the whole time, all of us know that this patient's going to die. Our oxygen's going down. There's nothing we can do. And they're not going to be able to get to us. And we did get a phone call. It was about 4 hours in. I want to say 4.5 hours into this. We've been sitting in the dark for 3.5 hours. And they call and say, you guys need to prepare for the worst. We lost contact with search and rescue because they also don't have cell service. So they got to a point where they were trying to get to us that they couldn't hear from us. They weren't able to get communication through. So they said, we don't know where search and rescue is. One of the other pilots from our base had actually taken his 4-wheel drive and tried to get to us. And he was the one that said, I can't get up there. Like, there's no way I'm going to be able to get up there. And so they called us. They said, you guys need to prepare for the worst. And at that point, everybody in the helicopter just got very quiet. That was the point where we actually lost hope. We had hope up until that point, and that was a point where, and I'm actually getting chills just talking about it. I can't even tell you or describe to you that feeling of patient's going to die, and now actually I don't know if we'll make it either. Like, I don't know, because it was very, very cold. Is bad. And then what really hit me the hardest was that I had taken this patient out of a facility that had exactly what he needed at that time and put him in my helicopter that now has nothing that he needed to stay alive. And the gravity of what we do hit me so hard. It still brings tears to my eyes when I think about it. So anyway, we don't really know what we're going to do. We're actually still sitting there. It's a lot quieter. Where oxygen is down to about 200 psi, which we started out with 1800 psi. Now we're down to 200 psi. So we don't have a lot. We don't have a lot of time left for the patient. And I saw headlights. And if you could have jumped up and down for joy in that helicopter, that is what we would have done, because all of a sudden everything was going to be all right. We had these headlights right in front of us. And so these two vehicles, not ambulances, these two 4-wheel drive trucks show up with 6 Navajos, who was what consisted of their search and rescue, that had literally spent the last 5 hours building a road and running off the road to get to us, just to get to us, little old us. We're nothing. They risked their lives to get to us. So they showed up. We had to take the patient out of the helicopter. We don't have a stretcher because they have pickup trucks. That's all they could get up there. So we had to wrap him in a blanket, take him out of the helicopter, put him in the back seat of a truck, and take him down off of this mountain. We unloaded some of our equipment. We weren't able to get into the back of the helicopter, which coincidentally was where the survival bag was, because it was frozen shut. You couldn't even get the door open.
No way.
Yeah, it was frozen shut. None of us could feel our hands, feet, any of that. And so these beautiful, amazing 6 search and rescue gentlemen got us out of this helicopter into the back. They had bought oxygen with them. So we hooked the patient up to oxygen, and we spent the next 4 hours sliding down off of this mountain on this road that they had built for us, literally with their own hands and whatever, to get us off of this mountain. We ran off the road a couple of times. And I just remember my partner and I just kept looking at each other like, can you believe this is happening? And she's like, no, No, I can't. I mean, it wasn't funny, but it was like, what are we doing? It's 3 o'clock in the morning and we're sliding down this snowy dirt road in the back of a pickup with a patient that's hooked up to oxygen and a ventilator. So we got down off of this road to an ambulance waiting for us at the actual road, where we were able to transfer the patient into the ambulance. Upon time, I did actually intubate him because he had gone apneic periodically. I don't know whether he had just finally run out of just run out of all of his reserves, or if my Ativan had really hit when he started to warm up a little bit. The Ativan probably really started to take effect. And so I did intubate him. I got my first intubation, which was not the most exciting part of the day. People always talk about
truck
in the back of the ambulance. So I actually waited till we got down to the ambulance. So a lot safer. Yeah. But still, people talk about, oh, hey, when was your first intubation? And I was like, well, it wasn't the most exciting part of my day, which usually it is, but was not that day. Yeah. Right. I know.
Wow. So you're
intubated.
You guys are just in shock that everybody has survived this.
Yes. Oh, wow. Yeah. Especially the patient. The patient was obviously your primary concern because he was the one in the most danger. Out of the 4 of us in that helicopter, that patient was in the most danger. Drove an hour back to the facility where they knew we were coming, and they were amazing. Warm blankets, warm, kind words, got us taken care of. And then we were able to be driven back to base, where we were taken off the line for a couple of days to debrief and process. And because then it does hit you what you've just been through. So
what was that like? When you say because I'm thinking, and I'm an emergency nurse, but I am not a flight nurse. I've never done flying, but we see a lot. We know that medevacs constantly, it's maybe they're bringing more attention. I shouldn't say constantly, but it feels like quite often we're seeing so many accidents, and you know that that's a risk. So how did it feel? What does that feel like when you take a flight knowing you may not land? And now you are in a position where you were in it. What does that feel like to this day?
To this day, it feels like a little surreal, but it also brings a resounding voice where safety is always first. And they teach us safety. They teach us safety to the nth degree in new hire all the time. But you can't take into account the feelings that you have when you want to save a life. The drive that you have to get in that helicopter because you know you're somebody's only hope to make it through the day. So that takes precedence over your own safety, and it shouldn't. And I will preach that it doesn't to anybody. But when you put yourself in that position, you make that choice because you know that you're somebody's only hope. And how do you take that away from somebody? All the safety in the world can't take away somebody's desire to go save somebody else's life, if that makes sense.
I mean, sacrificing your own life, Claire, to save somebody else. I mean, that's what nurses do. And I just have to say, and everybody listening right now, if made it through this podcast and your palms aren't sweating, a goosebump, something has had to have happened. But I want to use you as an encouragement because you embody what nurses are. You are compassionate and kind and competent and courageous. And your skill, you're willing to sacrifice. I commend you. And I think you telling this story is just such an honor. After everything that's going on in nursing right now, it's tough out there. And we all know it. Nursing is a very hard field right now. And I'm glad that we had you come on and tell this story because this is what I want us to not lose hope that this is who we are. You are the face of what nursing is. Smart, competent, kind, compassionate, courageous, all of the things. And what you're saying now, even in such a tragedy, you're still out there doing it. You are still out there flying, taking care of these patients and setting the example that, this is what nurses do. We save lives. We go out there and we help others. And I want no nurse to forget who we are, no matter what is happening around us. Don't lose sight. Don't lose sight of who we are as nurses. And no matter what society or patients or administration, whatever anybody says, be a Claire. I love it. I feel like I need a button because you really are an inspiration with this story. And I'm really glad that you're out there and teaching other nurses that even in the worst, you have persevered, and it's such an honor. So
Thank you.
What are some key takeaways? I feel like you need to tell some nurses, especially coming into flight nursing. I know lots of my baby nurses that I've trained over the years have wanted to go into flight, and that's their goal. What's some advice that you can give the new nurses and the experienced nurses out there in flight or not in flight?
The biggest piece of advice that I could give you is you already have a voice, because you wouldn't be in nursing if you didn't. That same voice that makes people sometimes difficult to get along with, because you speak your mind, you speak your truth, you advocate for your patients, you go against perhaps a doctor or another nurse because you know something's right. So you have a voice already when you get into flight nursing. Don't lose that voice because you are so enamored by what it is. All of a sudden, you are this big, bad flight nurse and people look up to you. Keep that voice for yourself, because there is going to come a time where you have to say no to a flight, or you have to say, hold on a second, there has to be a different way to do this or another way to do this. Don't lose your voice. Keep a hold of everything that has gotten you to this point, and don't let that stall. Stay an advocate for yourself. I can say above your patients, but I know you won't, because that's not what we do as nurses. I wish you would. I wish I could, honestly, but I can't. So, but stay that voice and be that voice for yourself. In all nurses, not just in flight, when you go to work, you are risking your life, because emergency nursing, med-surg nursing, ICU, they all come with risks, especially in this day and age with violent families, violent patients, bullying in the workplace, bullying from corporations. Just keep on doing what you're doing, because I promise you that the lives that you're touching, not just the patients that you take care of, but the family members that see you doing that are going to look up to you and remember you 10 years from now. Just a very, very brief story. I took my daughter to go get a colonoscopy, and the nurse that took her IV out looked at me and said, "Oh, hey, do you still work in the emergency department?" And I didn't recognize her. And I said, "Oh, no, I don't. I'm working in flight now." And she's like, "I just want you to know that you're the reason I became a nurse." And I don't know who she was, but at some point I must have touched her life, whether she was a family member of a patient, enough and not even known it. So you go out there and know when you come home from a really awful day, that even during the course of that day, you've touched somebody's life and made them the next best, greatest nurse. So just keep doing what you're doing and know in your core that you're doing the right thing.
That's awesome. Claire, this has just been such a pleasure and such an honor to have you on. And for those of you listening out there, we'll have some information for you if you want to ask Claire questions or just need some encouragement or support. This has been great. And I just want to thank you again for being vulnerable to tell your story, to be honest. You are such an inspiration. And just from hearing you talk, you really have touched my life. And the story that you told has just been awesome. And it has been my honor and my pleasure to be able to have you on and tell it. So thank you so much for coming on.
Thank you, Jana.
And thank you guys out there for listening. Absolutely. Thank you so much. And I hope to see you next year at the BCN conference. And all of you guys listening out there, I hope this story really encouraged you. And just remember, it's a great day to be a nurse. You guys mean so much. You are so important. You are so valuable. And it is just an honor that I get to serve all of you. Y'all have a great day. Thanks again, Claire.
Thank you.
Thanks for joining Nurse Converse, brought to you by Nurse.org. Help us grow by leaving a 5-star rating and review on your favorite podcast platform. Nurse.org supports nurses with career and education tips, life advice, and breaking news. Thank you for all you do and for being you.